So the ENHANCE CRT was a double-blind, randomized controlled clinical trial which aimed to assess the impact of LV lead targeting to enhance response in the non-left bundle branch block population. And what the study basically did was compared the conventional anatomical implant strategy versus a more directed, targeted approach using electrical delay. The study was, as I mentioned, a double-blind, randomized controlled trial, which included about 248 patients who were randomized in a 2-to-1 fashion down towards the QLV arm versus the standard anatomical implant strategy arm. The strategy of implantation was unique in the QLV arm, where patients, the lead was tested in more than one branch of the heart. And the QLV, which is the extent of electrical delay from the surface QRS of the sensed EGM from the LV, was actually assessed on all the 4 cathodes in 2 different branches. And then the branch with the best delay was actually selected for implantation of the lead. In conjunction with this, every patient had a 2-view angiogram, so that we could actually analyze where the segments were before we decided where the lead was eventually implanted. And what we did with this study was, after randomizing them in the 2 arms, they were then followed up for a year, and their clinical composite response was assessed, and even hard endpoints such as cardiovascular death and heart failure hospitalization was assessed. So the findings of the study were very interesting. As I mentioned before, the non-left bundle branch block patient population is a very underrepresented population in the heart failure group and in patients who receive resynchronization therapy. In the past, actually, it's a group that has been said has a very poor response and may not benefit from resynchronization therapy. So the important first finding was that we actually found that these patients did pretty well with resynchronization therapy, and their response rate was as high as 68 to 72%, depending on which arm they were, whether it was the standard of care arm or the QLV arm, but nevertheless a substantial response out there in this underprivileged patient population. Over and above that, we did find that there was really no difference in the 2 implant strategies. So the QLV arm was not superior or inferior to the standard of care arm. And I think a part of that arises from the fact that there was a fair amount of overlap where the leads eventually landed up in both strategies. And we're still trying to tease out if there was some signal that we can ferret out from the lead location, the QRS duration, and the extent of electrical delay. But at least at the, I would say at the balcony view level at this point in time, both strategies were comparable. So I think the ENHANCE CRT certainly throws open the question again that maybe we should not be writing off non-left bundle branch block patients. I mean, it is a patient population that actually responds quite well if they get good care. And 70% of them responding, I think, really means a lot, that we should continue to care for these patients. With respect to the implant strategy, I would say that both strategies are comparable. So it would not be fair for me to say that one is better than the other. I think the standard of care implant strategy works just as well as long as we implant the lead somewhere along the free lateral wall in the posterolateral or the lateral wall region. I think those patients will continue to do quite well. We still need to study the non-left bundle branch block patient population. I think there is a variability probably in response within the certain subgroups. There are different kinds of non-left bundle branch block patients. And that's something as a sub-study we're going to evaluate in greater detail. But I think, I don't think that we have reached the final answer in terms of how do you individualize care in these patients. I think we still need to find out what the interaction between substrate, electrical activation sequence are, the presence or absence of scar, and how then can we individualize our LV lead implantation strategy in this population, I think still needs to be determined.